the three talks, we're going to have some time to convey those questions to the speakers, and we're going to try to have a little nice discussion. So I'm going to pass the floor to Dr. Stephen Graves. He's a medical physicist and assistant professor at the University of Iowa. I've been lucky to work with him on some different efforts, including quantitative imaging and dosimetry. And Dr. Grace is going to start by talking to us about the emerging role of quantitative SPECT in Theranostics. So Dr. Grace, the floor is yours.
Thank you very much, Carlos. And it's a pleasure to be here. I want to thank Spectrum Dynamics for organizing this webinar, and I hope to see many of you in attendance to this webinar at the annual meeting in Toronto just here in a couple of weeks. So the title of my talk is The Emerging Role for Quantitative SPECT in Theranostics. I'm tend to focus on radiopharmaceutical dosimetry for oncology applications, but quantitative SPECT is by no means limited to oncology applications. I think that one of our other speakers, Dr. Auer, has given a number of presentations on cardiac amyloidosis, brain imaging, and a number of other applications in quantitative SPECT. But I'm going to focus my talk primarily on radiopharmaceutical therapy. So these are my disclosures. So we're going to start out with quantitation. So how and why. So maybe first the why, and what's the background on quantitation in nuclear medicine. Well, I think it's clear that PET-CT or PET has been viewed as a quantitative modality, ever since it was developed as an imaging modality in the early 1970s. PET has inherently been used to quantify the becquerel in a particular volume, and it has always been viewed by the scientific community and then later by the medical community as a quantitative measurement device. SPECT-CT, on the other hand, has typically had more utility as a qualitative imaging tool or a relative quantitative imaging tool. But that doesn't mean that people haven't been working on quantitative SPECT for quite a long time. In fact, if you look back in the literature, there are some excellent papers by figureheads in the field, such as Ron Jazak and Frank Whitehead, Ed Coleman, talking about the physical factors that you need to think about to enable quantitation, routine quantitation in SPECT-CT. So really, it's only been in the last 10 years that many of these things have been implemented in modern scanner designs and softwares. But that doesn't mean that we haven't had a good handle on the basics of what would be required to make SPECT quantitative over time. And so what is the impetus now for implementing quantitative SPECT-CT? Well, we know that historically radiopharmaceutical therapies have had a relatively wide therapeutic window, particularly in the case of radioiodine for thyroid cancer. With these newer approved therapies such as Lutathera or Pluvicto for neuroendocrine tumors or prostate cancer, it seems that the therapeutic window is narrower in a sense that we're not curing patients like we do with radioiodine, and we have a increased likelihood for adverse events, so bone marrow suppression, salivary gland toxicity, and other complications associated with the procedures. So it just seems that the therapeutic window is becoming narrower, and the utility for quantitative imaging is likely going to increase with time. And that's likely to be true for other agents that are approved subsequently after investigation. So we know that dosimetry matters, quantitation of radiation dose matters. In fact, the DosiSphere study explored this with Y90 microspheres. And the study found that ensuring that hepatocellular carcinoma in the liver getting over 205 gray increased overall survival compared to the other arm from 7.1 months to 26.6 months. And this is a really revolutionary outcome when you can triple median overall survival just by ensuring that the tumor gets enough dose. It becomes clear that the quantitative imaging and dosimetry really does benefit patients. And so what about our current radiopharmaceutical therapies? We're tending to treat patients all the same way, giving 200 millicuries with some minor adjustments based on empirical toxicity. But if you look at the actual absorbed dose to critical organs and to tumors, the kidneys, for example, with Lutathera have a 6-fold range in different absorbed dose between patients. For marrow, it's a 10-fold range. For Pluvicto or PSMA 617, the range of absorbed doses per administered activity is even wider, a 14-fold range for kidneys, 25-fold range for marrow. So some patients have very, very low absorbed dose per administered activity and could likely benefit from significant escalation in therapy, whereas other patients that have elevated dose to normal organs maybe could benefit from dose reductions or perhaps declining to treat them entirely because the tumors are unlikely to get a therapeutic quantity of the radiation dose. So these are just two examples, but now we have more than 70 companies in the field that are developing new radiopharmaceuticals. There are now more than 180 different radiopharmaceutical agents in preclinical work and at least 60 that are now in clinical trials. This slide is courtesy of Lance Burrell, who did a very nice survey of the field this last year. So I think that the use for quantitative SPECT, given this landscape of emerging radiotherapeutics, will certainly increase in value over time. Okay, so how do we approach the problem of quantitative SPECT? Well, the fundamental design of conventional SPECT scanners or gamma cameras hasn't really changed that much since the early 90s. I'm sort of showing a two-headed system. This is a SPECT CT system. Hybrid imaging systems are a relatively new development. But the SPECT scanner itself, you can see that we implemented bialkali PMTs, pulse arithmetic, having smaller photomultiplier tubes, improving our quality control, and then removing the light pipes and implementing digital electronics. And that got us down to an intrinsic spatial resolution of around 3.5 to 4 millimeters in the early 90s. Well, I just installed a brand new Siemens SPECT CT scanner in my clinic 2 weeks ago, and the intrinsic spatial resolution of that system happens to be exactly the same, about 3.5 millimeters. And so the fundamental technology, the sensitivity of the crystal, the design of the hardware has really not changed very much until the last 5 years. So I think that there have been some real innovations in scanner design, and I think that this is a really, really promising for the field of nuclear medicine overall. These 360 CZT cameras are quite different than conventional scanner designs, and I know that Dr. Auer is going to talk about these systems in detail after my presentation. But it really is exciting to be in the field of molecular imaging with these new single photon imaging systems. So there have been some trends, even among conventional scanner designs, to move away from giving physicists or clinicians or technologists the raw data, the raw projection data to process, including scatter projections and a variety of other things. They're moving towards more of a black box type approach, much like PET scanners have. So the good news is that we have potentially some automation that's being incorporated into new scanner designs and software. The downsides are that from a physics perspective, it's always nice to be able to check the data sort of manually with including scatter windows and including the projection data to evaluate for image quality before reconstructing the images. That may be going away in the future, much like it has with raw PET data. But there are some benefits in terms of quantitation with that as well. So if you look back at Ron Jazak's paper from 1981, what are the things that he said that we should be looking at? Well, this is sort of a comprehensive list. Some of these are pretty well taken care of, such as background, detector uniformity, positional linearity. We have good calibration and quality control measures in SPECT for those parameters now. So really the three that you have to worry about in modern SPECT to take a system that is otherwise qualitative and make it quantitative are system sensitivity, count rate performance or dead time, and then the spatial resolution of the system as it applies to task-based quantitation. So how do we handle each of these factors or considerations with a conventional gamma camera? Well, you have to come up with some way of measuring the sensitivity of your system. So there are some ways that provide a reasonably good agreement, such as the methods that have been developed in the US, Australia, and Europe. I'm showing a tissue equivalent plastic cylinder that we're using with the SNMMI Clinical Trials Network to calibrate scanners for clinical trials. Australia, courtesy of Dale Bailey, has implemented a small volume within the NEMA Phantom that allows for quantitation, as well as the European approach, which is essentially the same as the PET-based calibration, which is a 20 centimeter uniform cylinder. And you can see that if you just image a syringe or a point source in air or a Petri dish, you can really have significant errors in the sensitivity calibration for a scanner. But if you use one of these more robust attenuation and scatter inducing geometries, you get functionally good agreement on the scanners that I've had the opportunity to compare these approaches on. With respect to spatial resolution and partial volume correction, this is really relevant when you're talking about dosimetry or quantitation of small objects and images. We typically think about recovery coefficients in terms of the mean concentration within a tumor or within a small tissue like the parotids. And so you want to characterize the spatial resolution of your system. And there are a number of phantom choices that you might select for this. You might use the NEMA phantom, which has fillable spheres. You might use a small anthropomorphic phantom, but the larger and more representative of the patient geometry that you can achieve, the better, because the closer the detector heads are to the patient, for example, you start to get unrealistically good spatial resolution. So having the detectors at a reasonable distance from the lesions is ideal. Although these phantoms are quite complex and not widely available, and so you will continue to see people using the NEMA phantom for recovery coefficient measurements. With the advent of 3D printing, you can start to become creative, and you can make organ-like fillable objects to place in phantoms. These make for great projects for undergraduates or biomedical engineering students, and they can make these fillable inserts based on RT structure files from actual patient anatomy. The third consideration is dead time, and the bad news is that the dead time is quite complex to correct for in routine practice, and the reason is all of the counts hitting the detector matter, not just the ones that end up in your energy windows. So it becomes challenging to actually measure in a routine way the true count rate that's incident upon your detector, allowing for a sort of post-processing based dead time correction. The good news, though, is that under most circumstances with post-therapy imaging and with dosimetry, dead time tends to be less than 5%. And so this is one of those effects where you maybe just roll it into the uncertainty associated with the quantitation, unless you plan on doing very high activity or very high count rate imaging on conventional gamma cameras. So in summary, what we do for taking a site that is sort of built for qualitative SPECT imaging, and we want to take that site and we want to make it suitable for clinical trials, or they want to start doing dosimetry routinely. The three main steps are: one, make sure that the dose calibrator is configured such that it reads in true activity, not just what the nominal dial setting provides. You also want to calibrate the scanner to give accurate activity per volume or activity concentration. And then you also want to characterize the spatial resolution characteristics of your system. And these three steps are generally sufficient to take a otherwise qualitative scanner and turn it into something that can provide quantitative images. Okay, so what about dosimetry? Well, now that you have a scanner that is sort of able to provide quantitative measurements in dosimetry, we have a number of software options now available for doing actual dosimetry. So we have MIM, Voximetry, Hermes, and a number of other options. And these softwares have some similarities and some differences, but in all cases, the input is a quantitative SPECT scan to be able to actually calculate the absorbed dose. Many have some very nice AI-assisted contouring tools, as well as the ability to generate 3D dose maps. So these are all sort of modern innovations in the quantitation space for radiopharmaceutical therapy. So what about the dosimetry process do we need to know? So the title of this whole webinar is The End of an Era of Planar Imaging. Well, is that supported by the data? So the moderator for the session, Carlos, as well as a number of other individuals from the SNMMI dosimetry task force, put on a dosimetry challenge where they published a couple of really nice data sets and gave anyone who wanted to participate the opportunity to calculate radiation dose to critical organs and tumors. And they looked at what are the factors that impact uncertainty or variability in the dose specification. And so they started by giving people just planar images, and then they gave people planar images and SPECT-CT images, and then they gave people only SPECT-CT with some ROIs that are already drawn. And they looked at how does the variability in different reported dose values change as you sort of move towards more quantitative, more modern imaging techniques. And the results were really quite nice and show that if you just give people planar imaging data over on the left side of this plot here, you can see that the coefficient of dispersion is sort of 40 to 70%, depending on which patient we were looking at. And as you move towards just using SPECT-CT, you were able to reduce variability down to the below 20% mark quite easily. And you could reduce variability even more by standardizing the way that the regions of interest were drawn, or by the way that the time activity curves were fit. And so all of this is building support for doing SPECT-CT routinely and not using planar imaging for quantitative applications, including radiopharmaceutical dosimetry. And so I think there is a real trend in nuclear medicine towards really taking advantage of what SPECT-CT can do for you. Now, there are some confounding effects. So obviously, when we take an image of a kidney or we take an image of a tumor, we're getting sort of a macroscopic picture of what the intra-tissue distribution of radiopharmaceutical looks like. So we don't expect that the absorbed dose values that we get from imaging are going to correlate exactly with external beam type dose response or dose limits. And so this is just showing the differences in dose distribution. If you take a known distribution, this is an IQID image, and you apply a dose kernel that describes a high energy beta, a low energy beta, or say an alpha emitter, which is essentially local deposition, you do get very different microscopic dose distributions, which are going to manifest differently. And we simply need to characterize the dose effect relationships. But that doesn't get us away from still needing a macroscopic mean dose to organs of interest and tissues of interest, which quantitative SPECT enables. So I have a couple of quick dosimetry examples just to illustrate the utility of SPECT-CT. And so this first case is a thyroid cancer patient with a significant metastatic burden in the lungs. And so this is one of those patients where they're high risk and you want to give them as much iodine as you can to at least delay progression of their thyroid cancer. And you can get a conventional whole body image and you see, yes, there is significant lung uptake, but you don't know what the mass of the lungs are. You don't know what the actual activity is from this image. You can kind of quantify a percent uptake, but it's really a very uncertain calculation, and it doesn't allow you to calculate the dose per administered activity to the lungs. On the other hand, if you actually get the SPECT-CT, you gave this patient a couple of millicuries for mapping, and then you did a SPECT-CT, and maybe you found 900 microcuries in the lungs, so that's a 45% lung uptake. You can use that information along with the CT information to calculate the maximum tolerated activity. In this case, if we wanted to treat to bone marrow tolerance, we would have given 150 millicuries to get to 2 gray to the bone marrow. But in this case, the lungs were limiting. And so if we didn't want to exceed 30 gray to the lungs, we couldn't go over 105 millicuries. And so that ended up being very close to what we gave the patient, is around 100 millicuries. This is another example. This is a patient who went through a course of Lutathera and had significant benefit. So they had a partial response for their first 4 treatments with Lutathera, and they had very slow progression and generally good quality of life for 3 years. But then they progressed to the point of sort of needing additional therapy, and they were considered a candidate for PRRT retreatment. And the consideration was, well, if we don't know what they got in their first course of therapy, how can we treat them safely? And so what we do in these patients is we'll start doing dosimetry with the 5th cycle and try to extrapolate back to what they might have received in the earlier cycles. And so by virtue of doing that, I don't have the image from their middle cycle, but by quantifying the doses for cycles 5, 6, and 7, we're able to get sort of a reasonable range of renal doses for this patient. And we found that with an average renal dose of 4.1 gray per cycle, we felt comfortable going to 7 cycles in total to a 29 gray, give or take, renal dose. We didn't feel 100% comfortable giving that 8th cycle, but this is a nice illustration of how you can use dosimetry to sort of build the confidence to treat patients appropriately and go beyond sort of typical treatment limits. So a couple of practical considerations. What about reimbursement? What about the cost of quantitative SPECT on the healthcare system? What about the speed of planar imaging versus SPECT imaging? Well, the good news is that people are being reimbursed for SPECT-CT. This is an article that was published in the Journal of Nuclear Medicine, sort of illustrating the types of CPT codes that could be used for dosimetry. And to my knowledge, people are doing SPECT-CT after therapy and getting reimbursed for it, which is good. But what about the burden on our healthcare system? Meaning, are we sort of unnecessarily adding to the cost of therapy? Well, if you look at the actual cost of the imaging as well as any kind of dosimetry codes, it really pales in comparison to the cost of the drug. And so if you think that the quantitative SPECT imaging to allow for treatment monitoring, evaluation for progression, evaluation for response, as well as potentially dosimetry adds value, it really is worth doing because it's a small fraction of the total cost of care. So the burden of proof to do imaging, in my opinion, the burden is relatively low. You don't have to show that it benefits much. So what about planar imaging? So are there still any reasons to do planar imaging? Well, the three that you might typically hear are that planar imaging is faster than a typical SPECT scan. It can emphasize superficial anatomy. So if you're looking at the kidneys, for example, maybe you get a posterior view and you can see the kidneys more clearly. And it allows for dynamic imaging. And so of these, I think that I would challenge the first one. The second one can be generated artificially. So you have these technologies to make pseudo planar static images from a SPECT scan. So we have the ability to generate that if that's preferred. The only real benefit, I think, is dynamic imaging. So we're really not going to be able to do dynamic SPECT except under very low count density conditions. So that's really one area where I think that planar imaging may remain. But in terms of the speed and the superficial anatomy, I don't think that's a real hurdle. So the question is, does a quantitative SPECT CT really take 30 minutes? I think that Ben will probably touch on the acceleration of imaging in his talk, but I just want to point out that this is a really, really great abstract showing some of the dosimetry results from the Action 1 study. And what they did is they administered roughly 200 microcuries, 250 microcuries of actinium dotatate to patients. And the therapeutic level for actinium dotatate is so low because you end up getting several alpha emissions with each decay, and because the half-life is relatively long, and because the high LAT radiation has more biologic effect, you end up getting very, very few counts out of the body. So they imaged these patients for 1 hour, and they were able to get reasonably precise measurements of renal dose, of liver dose, of other critical organs. And so if they're able to get reasonably good dosimetry data from 200 microcuries of administration in only 1 hour of imaging time, does that mean that I can acquire a similar quality of lutetium data in 3.6 seconds because we're giving 1,000 times more activity with lutetium? Well, I don't think we can push it that far, but it is realistic to say that you can obtain quantitative information at sort of the macroscopic level with something like 1 minute per bed position. I wouldn't recommend doing that if you plan on looking at the images for any qualitative applications, but specifically for dosimetry, you really don't need that many counts or that much imaging time to get useful information. So I'm just going to push back on the fact that planar imaging is faster. If you're only using it for quantitative applications, you can do a really rapid SPECT scan and get valuable data. So in conclusion for my presentation, quantitative SPECT is here to stay. Newer scanners are providing native support for quantitative SPECT CT, which is a benefit to the field. And soon we may call quantitative SPECT just SPECT, just like we call PET PET. I mean, we don't say quantitative PET because that's implied, and maybe it soon will be implied for SPECT as well. So thank you for your attention, and I appreciate the opportunity to speak.
Thank you, Stephen. Okay, so our next speaker is Dr. Benjamin Auer. He is the Director of Nuclear Medicine Physics at Brigham and Women's Hospital and a faculty member at Harvard Medical School. He has been involved in several key initiatives and task groups, including the AAPM Task Group 417, which focuses on SPECT CT system quality assurance, and some efforts by the EAMM, EPUMP, and SNRMI for joining initiatives on gamma camera quality control. He has been doing research, including developing simulations for adaptive multi-pinhole SPECT systems for brain imaging. And his current research focuses on quantitative SPECT imaging for Theranostics and cardiac amyloidosis, 3D dynamic full-range CZT SPECT imaging, and motion correction for cardiac PET. So I'm going to pass the floor to Benjamin for his talk of rapid 3D quantitative full-range CZT SPECT CT imaging. Ben, floor is all yours.
Good morning. So thank you for the introduction and invitation to participate in this webinar. So yeah, it is crucial to recognize the current clinical demand for quantitative SPECT and its specificities as presented nicely by Dr. Graves in his first talk. And I think that it's also equally important to grasp like the practical limitation of current conventional technology and pave the way for future advancement to address the current clinical needs and also open new doors. So today I will explore in my talk the potential of full-ring CZT SPECT-CT for rapid 3D quantitative imaging. So I have no conflict of interest to declare. So I will briefly review the advantages of CZT detector technology for SPECT, move on to full-ring CZT SPECT-CT, explore the current clinical need for 3D dynamic imaging and the added clinical value, and then also discuss the potential of this technology for rapid quantitative whole-body 3D imaging, which holds invaluable promises for Theranostics. So digital CZT detectors are semiconductor arrays that directly convert the energy deposited into an electronic signal, and this direct transfer of energy and location information results on overall improved performance. So CZT technology has facilitated the implementation of more efficient camera design with high performance imaging geometries. So one example of such innovative system design are full-ring CZT SPECT-CT systems that are currently two systems available, the Starguide from GE and the Veritone from Spectrum Dynamics, with our installation marking the first in the US. So even though design might appear very similar, there exist major differences, such as, for example, originally the CZT detector were thicker for the Starguide. The collimator is also thicker so that it provides better spatial resolution but worse sensitivity compared to the Veritone. And recently, Spectrum Dynamics has released the 400 series with even thicker CZT detectors, capable theoretically to image up to 400K. So such systems consist of a circular ring of 12 CZT detector column associated to a diagnostic CT. So each detector column can rotate on their own axis. This is what we call swiveling, to focus on a given organ or structure of interest. And the detectors can move in and out to be positioned quite close to the patient for high performance imaging, so better spatial resolution. So full-ring CZT SPECT-CT offers improved imaging performance, so enhanced sensitivity and spatial resolution compared to conventional systems due to 360-degree geometry, closer contouring, and also detector swiveling. So in addition, such technology offers precise quantitation, thanks to CT-based attenuation scale correction, as well as resolution recovery in reconstruction. And as we will see later on, the images are natively generated in quantitative units in a similar way to what is done in PET. And then we can derive SUV values from the images directly. So, and finally, as well, 3D dynamic imaging, not feasible with conventional SPECT. So dynamic imaging with the widely available conventional system is limited to 2D. So for most clinical application with such system, the current standard of care is based on indirect imaging approach, I would call. So it relies on a combination of dynamic planar imaging to evaluate functional information, for example, liver function, followed by static and or single bed SPECT-CT to detect and quantify abnormalities. So however, this approach is limited inherently by the 2D aspect of planar imaging, and full-ring CZT SPECT can overcome such limitation via quantitative 3D dynamic imaging, offering enhanced quantitation plus information in 3D, so no overlaps of structures. So one great application of 3D dynamic imaging is for preoperative liver resection imaging. The idea is to evaluate the remnant liver function to predict the risk of post-hepatectomy liver failure. This can be done via SPECT imaging prior to surgery. So the current standard of care is based on this indirect approach with conventional SPECT system, relies on a combination of a dynamic 2D planar imaging to evaluate the liver function, and SPECT CT to segment the liver into remnant and resected region. So full ring CZT SPECT improve accuracy via like quantitative 3D dynamic imaging, as we would say. So with the standard semi-quantitative approach, the first phase aims to evaluate the total liver function from dynamic planar 2D imaging. The liver function is estimated via like time activity curve integration. And the second phase then consists in estimating the proportion of counts accumulated in the remnant resected portion. And we can then combine liver function estimated from dynamic planar imaging with remnant resected count proportion from the static SPECT CT via like the HIBA index representing basically the proportion of radionuclides uptake accumulated in this region. And finally, we can compare this value against like population-based cutoff measurement to determine the risk of post-surgery liver failure. So as we may understand, this approach is suboptimal. With full ring CZT SPECT, we can evaluate directly the remnant liver function via 3D dynamic SPECT imaging without the need for the static phase. And also the quantitation, HIBA quantitation is expected to be more accurate as we do not have like superimposition of activity, which is the case with planar imaging. So using 3D dynamic SPECT, we can now follow the tracer uptake in both liver lobes, so remnant and resected, opening new doors for quantitation of direct evaluation of remnant and resected function. 3D dynamic imaging is also of crucial interest for cardiac perfusion imaging as it enables myocardial blood flow quantitation, particularly useful for diagnosing coronary artery disease. We can see here a 6-minute 3D dynamic rest-only scan acquired on a Veriton, and the flow is evaluated from the integration of the myocardium and blood through time activity curves via like kinetic model. So for some application, semi-quantitation is not sufficient, as for example, for SUV, or personalized dosimetry for Theranostics, where the goal is to estimate the absorbed dose in specific region of interest delineated on SPECT images. So these require absolute quantitation of tracer uptake, and to achieve this, we need to calibrate our system so that we can transform image counts into activity concentration. And the correction factors is directly implemented in the software. So no third-party vendor nor additional quantitation packages are necessary as it is for conventional system. So for conventional system, calibration factor is usually derived from a planar acquisition of a cylindrical phantom simulating realistic scatter level, as described by Stefan earlier. So dead time also needs to be corrected in practice, and producing the images in quantitative unit requires a third-party reconstruction software or additional quantitation package. So for full ring CZT SPECT, the calibration factor cannot be derived from planar acquisition, as the sensitivity depends on the VUI size in focus mode and also the object to collimator distance. So such effects are included and corrected for in the reconstruction. So an easy workaround is calibration is usually done by reconstructing the acquisition of a uniform flood cylinder similarly to what is done with PET. So the system is calibrated against a dose calibrator using a source of known activity. It is important that flood phantom is acquired with the same clinical acquisition and processing parameters that the system should be calibrated for to avoid increasing variability introduced by differences in technical factors. So JSAC phantom acquisition are part of the periodic QC of any SPECT system, so it would thus be convenient to estimate the calibration factor from the uniform phantom region of such acquisition. This would thus be easier than scanning an additional uniform phantom. So we have found that the calibration factor remains close to that derived from a uniform cylinder, and we observed small impact on absolute quantitation assessed via like a torso phantom study. So, however, it remains difficult in practice to use JSAC or uniform cylinders for calibrating long-lived radionuclides. The need to simulate a realistic scatter medium adds another level of complexity. So recently, what we call a donut-shaped cylinder phantom with disposal plastic bottles has been proposed, and the calibration factor derived from such acquisition remains close to that of a uniform cylinder. So one of the most promising application of full-ring CZT SPECT is in the context of Theranostics. There is a major interest in personalized dosimetry and treatment response monitoring, where several scans at multiple time points with whole body coverage are strongly desired. So there is therefore a considerable need for high-speed whole body 3D quantitative imaging. So conventional SPECT suffers from exhaustive scan time and dependence on additional package or third-party software for SUV/dosimetric type quantitation. So the standard of care relies on a mix of whole body planar and single or dual bed SPECT on areas of interest. So full ring CZT SPECT has the potential to overcome these challenges by enabling rapid whole body 3D imaging with built-in quantitation. So it was demonstrated that a whole body skeletal SPECT CT could be performed in 20 minutes. A recent improvement on Veriton is the ability to modulate the detector contouring, where focus areas per bed are derived from the CTAC. And this results in further improvement in sensitivity, thus scan time reduction down to 10 minutes for a whole body bone scan. AI denoising can also be used to reduce the scan time even further, down to 6 minutes, while maintaining the image quality. So if we go back now to Theranostics, as we can see on this diagram, the typical lutetium herpetic dosimetry workflow for neuroendocrine or prostate cancer consists of multiple steps with extensive imaging session, followed by dosimetry of tumor and organ at risk for modification of subsequent treatments. So post-therapy planar SPECT CT or mix of both imaging can be performed at a single time point, less accurate but more convenient, or multiple time points, more accurate but also more time consuming. So there is thus like a considerable need for rapid whole body 3D quantitative imaging. So it was shown that the STAR guide was capable to image patient vertex to mid-thigh in only 12 minutes. In comparison, a conventional system, only 2 bed positions were recorded in twice imaging times. So there is a need also there is a need for additional planar, sometimes to cover the whole body, because whole body SPECT would be too long in practice. So the image quality remains also worse compared to that of the STAR guide, especially at the junction between the bed position. This illustrates again that such systems are not really designed for multi-bed imaging. And in addition, the dead space at the detector edges is much higher compared to CZT. So with the Veriton 200 series, only one peak of lutetium can be scanned, but a whole body lutetium scan can be performed with adequate image quality in about 80 minutes. And with the recent Veriton 400 series, you can image both peaks of lutetium and you can reduce the scan time down to 9 minutes. So SUV type quantitation has great potential for assessing treatment response and monitoring. We can also see one example here with full-ring CZT SPECT. So such technology enables quantitative whole body imaging in a reasonable scan time, making 3D whole body imaging at multiple time points feasible in practice. So another RPT that would strongly benefit from rapid whole body 3D imaging, in my opinion, is iodine 131, a treatment for thyroid cancer. The idea is to administer it prior to the treatment a small amount of iodine to predict the MTD, so the maximum tolerable radiation dose. MTD is evaluated via like internal dosimetry of organ at risk, so the marrow and the lung in this case, and requires multiple time point imaging and blood sampling. So single time point techniques have been proposed, but these remain less accurate, so not preferred in practice. So quantitative accuracy is also critical. So the dosimetry workup with conventional SPECT imaging relies again on a mix of whole body, 2D planar imaging, and single or dual bed 3D SPECT on pulmonary and thyroid region. Typically, so organ death compensation and attenuation correction are typically performed via conjugate view and cobalt transmission and blank scan respectively. Activity calibration is done via like a standard source, but the quantitative accuracy of planar imaging remains limited in practice compared to SPECT CT. And the workflow is quite extensive with multiple hour-long studies. There is therefore a strong need to move to rapid 3D whole body quantitative imaging. So from the time activity curves, we derive from the multiple time point imaging. We can derive like the residence times for tumor, organ at risk, and whole body can be estimated. So the marrow residence time is derived from the blood sample measurement. And finally, the absorbed doses are estimated via like RPT dosimetry software. And MTD is finally determined based on population-based dosimetric criteria. So as we have seen, such studies are complex, requiring multiple extensive imaging sessions and blood draw. Therefore, in practice, we only perform such for young patients and those with metastatic lesion, especially in the lungs, as it is an organ at risk. And it is my strong belief that with a rapid 3D whole body imaging solution, the workflow can be streamlined and quantitative accuracy improved as well. So this would facilitate the dissemination of dosimetry studies, thus more patients would benefit from such. And in this context, full-ring CZT SPECT might be like a practical alternative, probably too early to tell, but the preliminary results are promising. So one last RPT that would also strongly benefit from rapid whole body 3D quantitative imaging is radioembolization. RPT is based on injecting radioactive like yttrium microspheres into the hepatic lesion via like the hepatic artery. So such study is unique in the sense that the radiation via the microsphere is mainly localized in the liver, and single time point imaging for dosimetry is fine, and because we only have the physical decay to consider. So the typical workflow will consist of a pre-therapy technetium AA SPECT and post-therapy Bremsstrahlung SPECT as well. So as for the other RPT we have discussed earlier, conventional system remain limited, scan duration is too long. The standard workup with conventional SPECT will rely on this mix of planar and SPECT. Acquisition time is too long. There would be like a strong benefit to move to whole body 3D imaging. So conventional PET suffers from low sensitivity, thus not adequate in practice. However, recently several groups have shown that total body PET could be like a reliable alternative towards whole body 3D imaging. And full-ring CZT SPECT might also be an efficient alternative. Some areas of improvement remain, among which energy window optimization, also how to perform the calibration in practice. So in summary, very briefly, full-ring CZT SPECT offers improved imaging performance, rapid whole-body 3D imaging, and 3D dynamic imaging, with exciting application in Theranostics for treatment monitoring and personalized dosimetry. It also provides built-in quantitation, SUV and dosimetry ready. However, there are like needs to standardize the calibration and dosimetry procedures by establishing official guidelines. And I'm gonna stop here. I would like to thank my collaborators and mentors at the Brigham, Spectrum Dynamics, for their ongoing support of our clinical and research activities as well. Thank you.
Thank you, Ben. Now we're gonna have a talk by Dr. Nasreen Dersani. She is a nuclear medicine specialist in New York, affiliated with multiple hospitals in the area, including Mount Sinai Hospital and Mount Sinai Beth Israel Hospital. She is a physician, so she's not going to take us to the clinical perspective of quantitative SPECT. She has been in practice for more than 20 years, focusing on quantitative SPECT and SPECT. And Nasrin, just before you start, I want to remind the audience that you can type questions on the chat. That Nasrin, that floor is all yours. You're muted.
Thank you so much for the invitation for this talk. I'll mostly talk about the clinical application of the digital SPECT system. As a first year resident in nuclear medicine in late 90s, I remember asking question to my physics teacher that how come we have only 2-head SPECT scanner? How come we don't have a 3D gantry? And he started laughing at me saying that, do you know the cost of the crystal that will include, involved to make a 3D gantry? And all this time, we were hoping to have a nice 3D gantry acquisition for SPECT, and finally we have it available now. So as you know that 2D SPECT acquisition involves camera circling around the patient, and the cameras circles around patient every 3 to 6 degrees. So your angle of acquisition also causes some loss of findings because you are not taking images in reality in 360 degree. So the image quality suffers because of that.
So Nazreen, I think we're not seeing your slides moving. I think we still see your title slides, like your screen is frozen. So I think you might have to switch your display.
Is it changing now?
No. Okay, it changed now. So we're on the slide that says nuclear medicine design limitations, yes?
Yes. Okay. So if I change into this is the slideshow mode. So is it?
So no, we're seeing your slides. We're not seeing the full screen. I think you need to share the other monitor if you have another one, or the other window.
I'm sorry for the apologize for the is it
Okay, now we see the presentation. There you go. Thank you.
So, so the original gantry is a SPECT gantry that as I mentioned, rotates around the patient in 360 degree, but we do miss the sampling where every 6 degree. So the 3D gantry with the Veriton provides much more accurate sampling of the data. It models around the patient's body, so there is the acquisition detectors can come very close to the patient, and the image quality is a lot nicer with the Veriton. For clinician, these are the things that are very important. That patient scan time is decreased. Whole body SPECT can be achieved in 15 to 30 minutes. Less than 15 minutes for brain imaging for DET scan, where patients have Parkinson's disease and movement disorder. It's very difficult for patient to stay still. For lung scan, patients are short of breath. So the shorter acquisition time definitely is more exciting for clinician. Technically, as the previous two speakers spoke about, there are significant advantage of digital SPECT. The SPECT quantitation is also improved because of the better iterative reconstruction, scatter and attenuation correction, and now we are able to get the standardized uptake value with our images. Also, when you are doing the dosimetry, you can get activity per voxel, and that tells you the concentration of delivery radioisotope delivery agent into tumor cell. So when it comes to clinical scenarios, so there is a reliable diagnosis. It helps in therapy monitoring. There is a very good reproducibility. When you are doing clinical trials, the data are comparable between the multiple center, and there is a semi-automated analysis. So what are the clinical applications we can use this technique for? So we just started our using our scanner last week. So I have few examples of our own center, and there are several from the Veriton application that I received. So these are the whole body images, and you can see nicely how in this patient there is a fibrous dysplasia of the skull, Paget's disease of the pelvis, and this patient has multiple fractures. This scan can be accomplished within 20 minutes. When the scanner is closer to the whole body, the scan time can be increased to 3 to 4 minutes, where the details are more important. In the extremities where details are not as important, you can do the faster scanning. So these are the flexibilities that were not available to us before with the traditional Anger camera. Also, ability to get the SUV. So in this woman, this patient has a severe osteoporosis and has developed multiple fractures over the period of time. And so in the first scan, you can see there is a fracture in upper lumbar spine, and SUV is 20.9. 6 months later, patient comes back for the scan, and this fracture has healed, but there are several new fractures with higher SUV in the thoracic spine. So the SUV measurement is very, very important for patients coming for multiple bone scans over a period of time, for cancer, for an evaluation of the osteoporotic fracture, particularly for cancer, because most of the time we have a patient undergoing treatment in clinical trials, and they are getting scanned every 6 weeks, and we many times see very minimal difference in the image interpretation, in visual impression. But when you take the SUV, that it may help in predicting the treatment response effectively. This is one of our patient. This is a pre-therapy gallium-68 DOTA scan. He had a VI glioma and admitted in the hospital with severe symptoms, and he received the therapy. After 4 treatment, his liver is so much smaller. If you can believe, these both, this one is a PET image and this is the Veritron SPECT images, but they look quite comparable. The detail in the image quality is so much better than traditional angle camera. Here also you can see the liver size is decreased so much. The patient is responding very well. We have another example of this patient who came in to look for a patient with the lumbar spine, lower lumbar spine pain. The neuroradiologist wanted to find out where exactly the arthritic changes are, so he can selectively go and inject steroid in that facet joint. In this patient, the pain can be very diffuse and MRI can be abnormal at multiple levels, but the bone scan is predicting exactly where the most inflammation is, and this will help neuroradiologist in injecting into that particular facet joint. This is the patient with the neuroblastoma I-123 MIBG images. We always struggle with I-123 MIBG images in children with neuroblastoma. Even though we have a SPECT and better SPECT system, the image quality is still very poor, but here you can see very nicely the lesion in the left paraspinal region. Here is another patient undergoing Lutathera treatment. There are multiple lesions in the supraclavicular region, in the retroperitoneum. Over the period of time, patient is improving, and you can get the SUV measurement and see how patient is responding in all these areas. The focus mode imaging, which is actually where you can select the organ of interest, like the thyroid, parathyroid, brain, and you can image patient very close to the and get very detail of the organ. So there are several studies done with the eye of Lupin, and here in this one study, with the traditional angle camera, acquisition time was 30 minutes. With the Veritron, the acquisition time was decreased to 15 minutes. Even with the decrease in acquisition time to half, the count sensitivity was 50% higher with Veritron. Overall, there was a concordance between the image from angle camera and the Veritron, and there was no drawback of imaging patient with Veritron. This is again very important when patients are unable to hold still because of their inherent neurological disorders. So the shorter acquisition time is always better for them. So this is the normal eye of Lupin study. Here you can see nicely activity in the striata. And here there is an abnormal TET scan where you see uptake only in the head of the quadrant but not in the putamen. Another very good application is DMSA SPECT. Here there is a study comparing 21 patients undergoing planar angle camera versus digital SPECT with Veritron, and overall there was a concordance in 19 patients. In 2 patients, one was false negative and one was false positive by Veritron, but in reality both were actually so the false negative result on angle camera image there was nothing on this image, but when you look at the CZT spexity, there is a focal defect here. And on anger camera image, this lesion was called here, but it's a normal lobulation on CZT spexity. So CZT spexity was better than anger camera for DMSA imaging. This is our own VQ scan image. Patient underwent a VQ scan 2 days ago, and you can see the ventilation images are so poor. The patient had difficulty breathing, so very heterogeneous images. These images were derived from SPECT images. The planar images were derived from the SPECT images, and on the spexity images, you can see that there is a absent perfusion in the right upper lung, and there is a normal ventilation. Again, absent perfusion in the entire left lower lung and preserved ventilation. So this was a high probability VQ scan. Looking at the images, both ventilation and perfusion looked abnormal, but spexity definitely made difference in interpretation. Another VQ scan from this was from European Journal of Nuclear Medicine in patient with COVID. So patient was unable to breathe very well. So there is a deposition into trachea here, but there was a focal small perfusion defect in the left lower lung, and then right lower lung, and then over the period of time that defect actually became more pronounced. So very subtle defect that was very well seen by spexity. Then dynamic spexity. So we are all excited about being able to do GI bleeding scan, hepatobiliary study, and renogram. In GI bleeding, we can actually nicely pinpoint where the site of bleeding could be. For hepatobiliary study, many times our clinician friends are asking us to see if we can tell the differential function of hepatic segments, and that can be achievable by doing a dynamic SPECT acquisition during the HIDA. And in venogram, if patient has a duplicated collecting system, and if you can do the dynamic SPECT images, you can clearly outline upper and lower pole moiety with dynamic SPECT. So these are the future nice application that we are looking forward to using our scanner. This is just an example of GI bleed, not really performed on CZT, but the spexity was able to identify the bleeding site in the right colon. So this is the myocardial perfusion SPECT, very nice quality images compared to what we see with the SPECT, anger camera SPECT, no attenuation artifact and clear delineation of the myocardium. The possibilities are endless. I'm sure there are many uses of this system that we will see in coming days. Thank you.
Thank you, Dr. Yasani. Now we're running a little bit of over time, but there's a couple of questions that have been asked in the chat, so I'm going to pass them really quickly to the presenters. So the first one is being asked by Dr. Pedro Esquinas, and it has to do with dead time. And Stephen, you talked about dead time at the beginning with like conventional SPECT systems. Then Ben showed us like the new 360 CZT systems. So what's the impact of dead time on the new generation CZT scanners? Are they more or less sensitive than traditional SPECT? Is the dead time modeling from traditional SPECT systems applicable to new CZT-based scanners? Who wants to answer?
So thank you for the question. Dead time is a significant issue with conventional gamma cameras because there are really only two physical detectors, and the entire sodium iodide crystal is involved in the detection of each photon event. With CZT detectors, the detector itself is segmented, and each individual CZT element is mutually exclusive from adjacent elements for processing events. And as a result, the count rate performance for the same gamma flux is immensely better with CZT, pixelated CZT cameras. We've seen this in dedicated CZT cardiac systems for for many years, and now with the new 360 CZT whole body systems, the count rate performance is outstanding, and really dead time is insignificant on these scanners. If it's 5 to 10% on a conventional gamma camera, it's virtually 0% on a whole body CZT camera. So that's the good news. In terms of the sensitivity, the answer is that it really depends on the geometry of the object you're imaging. Conventional gamma cameras have a large detector area, which is good for geometric efficiency, but a lot of that is looking at air. And so the advantage of the 360 CZT detectors, despite having smaller total detector area, they're always looking at the anatomy of interest, and that can improve sensitivity, especially when you're focusing on something like the heart or a particular subregion of anatomy of interest. In general, I think that the sensitivity for whole body imaging is comparable, but again, there are some major advantages in terms of the proximity of the detectors as well as the detector material themselves.
Ben, do you want to add anything?
Yeah, so I totally agree with Stefan. So yeah, during our acceptance testing, just to provide a number, the maximum count rate for our Veriton was about 3 mega kilocounts per sec, with estimated 1% loss. So basically, virtually no dead time effect, in the clinical range.
Okay, it's good to know, as we think that personalized dosimetry might lead us into increasing injecting activity someday. So that's good.
Yeah.
There's another question asked by Dr. Elliot Siegel. Faster acquisition by CCT system doesn't necessarily mean that the accuracy is preserved. How can I become convinced to switch from a sodium iodine crystal-based system that I won't sacrifice accuracy, since the literature is reading using sodium iodine rather than CZT?
So great question. So yeah, so that's the whole point. Basically, making this scan, faster, but at the meantime, having like similar accuracy, right? So several studies have demonstrated that the accuracy is actually better with this, novel system for ring CZT SPECT CT, because you have like better imaging performance, basically, so better energy resolution. So you are better able to differentiate between scatter and primary photons, as well as better spatial resolution, because you can have like these detectors very close to the patient, so you improve spatial resolution. And sensitivity can also be improved. It will depend on the size of the region of interest. If you are using the focus mode, basically the smaller that region is, the higher the sensitivity gain will be compared to a conventional system. So you will definitely not sacrifice accuracy compared to a conventional sodium iodine system.
So the following up, so saying accuracy, meaning in the sense of quantification of dosimetry for radiopharmaceutical therapies. And so how can you convince people saying, okay, the conventional system and the new CCT system can have a price difference of about twice, so why should we move them into?
So I think the cost is also getting better. So with the latest generation of system, it's definitely not twice these days. So and I think you have like established application, clinical application now that would justify the additional cost. But in terms like of dosimetric accuracy, as Stefan has said in his presentation, dosimetry does not really depend on the number of counts you are getting on the image, right? So it depends really what you would like to achieve. If it's more like a qualitative assessment on top of those assessment, then of course the image quality will matter. But if you are just interested about quantitation, I think that a fast rapid scan would be the way to go, basically.
If I could add, I think this is one of the situations where you don't have to trust that the new scanner is the same as the old scanner. You can verify that with phantom experiments, also with imaging a patient on both scanners. You should be able to find evidence or ask the vendors to provide that evidence to you to better understand the characteristics of the imaging system. But it's a good question, but I think that really it comes down to physical experiments to verify the accuracy.
So Dr. Design, I wanted to also have a question for you. You showed us in the presentation, you showed us some nice SPECT images for bone scans. You showed us some SPECT images for I think it was pulmonary embolism diagnosis. But then you also said, look, so we acquired this SPECT, but we made them look like a planar image. So that I'm coming back to like the topic of the webinar. Is it the end of planar imaging? So do you still need those planar-like images, given that you can collect these quantitative 3D SPECT? What can you comment on that?
No, we really don't need to create the planar images. It's just, our eyes are used to of looking at those images. So we want the reassurance of what we are looking at by creating planar images. But I think once we start getting used to of looking at these images in 3 dimension, I don't think there is a need to create planar images from the 3D.
Yeah, so you think we're moving more into the 3D SPECT world as we move forward. Okay, yes. So maybe last question. Let's see the chat. Okay, so we need some understanding here as well. And so Ben, conventional SPECT systems, people were used to having different collimators. I will put the low energy collimator for technician, then maybe we'll switch to medium energy for lutetium. If we're even gonna do actinium, maybe we'll bring the high energy. But that doesn't seem to be the case with these 360 CZT cameras. So how does the collimator work here, and why is it so flexible in terms of going from low energies to high energies? Can you give us some details on that?
Yeah, absolutely. So that's a very good question. So yeah, with full ring CZT SPECT CT, you cannot change the collimator. So one thing to note is that the collimator is made up of tungsten on this system. So we have like slightly better stopping power that lead alloy. But so exactly. So the collimator is one element, but also the detector and the CZT thickness is also very important, because you need to stop the high energy photons, right? You need to detect these. So you need like a thicker CZT crystal. So in practice, I think we are seeing now preliminary results that then, iodine-131 imaging is feasible with this type of system. I mean, at least qualitatively, but quantitatively, we do not have like any evidence, that such system is able to actually produce quantitative images. I've shown like just some preliminary results in my presentation, but you could clearly see that there was like a higher penetration compared to a conventional system for iodine-131 imaging, because with a conventional system, you will use a high energy collimator, so you will have better stopping power. So yeah, I think it's just the beginning, and the story will continue, but we really need some evidence with phantom studies, and then with patient data that this type of system are at least as accurate as a conventional SPECT CT, right?
Okay, that being said, I want to thank the 3 speakers again, and virtual round of applause from the whole audience that was here. This was very insightful. Thanks for your time. Thanks for Spectrum for organizing this webinar, and we'll see you in the next one.